Hello, good evening everybody here from Tübingen in Germany. My name is Andreas Falgerter. I'm the head of the Department of Psychiatry here at the University of Tübingen, and it's my great pleasure and honor today to host the second of the Gallese talks. Professor Vittorio Gallese will talk about relationships, social relationships in schizophrenia patients. And we are glad to have such a distinguished speaker here who is well known for one thing mainly, and that was the first invention that was the invention of the mirror neuron system, which has been done in Italy and which has influenced neuroscience until now. And Professor Vittorio Gallese is a famous neuroscientist and also psychobiologist from the University of Parma, and now we'll talk about his second feature, and he's also working in the field of schizophrenia, and we are looking forward to hear your talk. So, John, maybe I can give you some technical remarks. Please note and send your questions during the talk. They will be here online, and we can have the questions online. I can read it, but you can also tell you by yourself. But I would be happy to have some questions in advance to have to moderate the discussion. And I already talked about with Vittorio, we have to finish our meeting in time to be on time for the football and soccer match this evening. But he has a full understanding for that. Vittorio, it's your stage. Please, we are looking forward to hear your talk.
Thank you so much. It's a pleasure and a privilege to be again in Tübingen, although only digitally for the time being, with this second talk where I would like to tell you something about our research on schizophrenia. I'm kindly asking you to allow me to show the screen, because I have a sign which tells me that screen sharing is not possible.
Our technicians are working on that.
Okay, so before I can share the screen, as an introduction, I should tell you that when I decided to start the School of Medicine a long time ago, my first choice was, I chose medicine to become a psychiatrist, but during my sophomore year, I had the chance to meet who was going to become my mentor, Giacomo Rizzolatti, and this diverted my interest from psychiatry to neurophysiology and neuroscience. But luckily enough, after a few years, I had the possibility to do part of my empirical research also on psychopathological topics, like the one I'm about to cover with you this evening. I slightly changed the title. It's not just schizophrenia and interpersonal relations, but the bodily self and interpersonal relations in schizophrenia. Maybe many of you still remember Siri Hustvedt, the American novel writer and essayist who was in Tübingen a few years ago for a poetic docentur. In this wonderful little book, The Shaking Woman, or A History of My Nerves, Siri Hustvedt wrote, medical history changes, and many, if not most doctors, have little grasp of what came before their own contemporary frames for diagnosis. So I would like to start my talk this evening to paying a tribute to an old, and I should add, mostly German-speaking tradition of psychopathology. The first author I would like to quote is Kretschmer, who in 1921 wrote, there is something common, something similar, something different only in degrees between character and psychosis. Between sick and healthy, there are all the steps and all the nuances imaginable. I think this dimensionality of psychopathology and psychiatry kind of clashes with the dominant contemporary DSM-informed take to mental illness. I think we should look back and consider this dimensional approach to mental disease, also because I don't have time to deal with this properly, but also from an ethical point of view. I mean, if we consider mental illness as one of the possible many ways of being humans, I think the purchase, both for the patients and the doctors, are huge. On a similar vein, wrote Ludwig Binswanger, who held that psychosis, alienation, is not understood as negativity with respect to the norm, but as variation, Abwandlung, of the a priori transcendental ontological structure in which the existence of the subject reveals its mode of being. With this old-fashioned language that we have forgotten, perhaps Binswanger make the same claim. To continue with the glorious German psychopathological tradition, one of the authors that really captured my attention back in 2003 was Bleuler. Bleuler, notably, was the German psychiatrist who probably got it right about schizophrenia when he proposed the notion of autism. And we know that, for example, back then Sigmund Freud, through the influence of Jung, who was a co-worker of Bleuler, tried desperately to convince Bleuler to change his mind and instead of autism, refer to autoerotism. But Bleuler kept still. And I think this notion of autism as the incapacity to be attuned with the world, constituting the basic clinical essence of schizophrenia, is still very modern. Another almost forgotten author in psychiatry, I think barely, if not at all, known in the English-speaking world, the author of one of the most interesting books on schizophrenia is Eugene Minkowski. According to Minkowski, the core problem of schizophrenics is their lack of vital contact with reality, which he viewed as an incapacity to resonate with the world, to establish meaningful bonds with other individuals. According to Minkowski, the schizophrenic autism can be framed in two ways, as poor autism or rich autism. According to Minkowski, poor autism shows pure schizophrenic disorder. And today, with a more modern phrasing, we could establish a parallel between Minkowski's notion of poor autism and negative symptoms. According to Minkowski, what is designated with rich autism, that we could connotate in terms of positive symptoms, is the result of the encounter between the primary disorder, the loss of the naturalness of experience expressed in the loss of life contact, and the compensatory processes, attempting to fill the resulting void. More recently, another famous German psychiatrist, Blankenburg, spoke about the autistic dimension of schizophrenia in terms of a global crisis of common sense, the incapacity to pre-reflexively grasp the meaning of the world. Schizophrenia, in Blankenburg wording, would amount to a loss of the natural evidence of the world. And to come to even closer times, Joseph Parnas, together with Beauvais and Dan Zahavi, spoke of schizophrenia in terms of a lack of attunement, which basically is the incapacity of schizophrenic patients to draw a coherent and meaningful picture of their social world. Here I'm quoting literally from a paper by Parnas, Beauvais, and Zahavi, published in 2002. Begin quote, experience is more observed than lived, most likely because of the incapacity to attain a non-reflective, tacit sensibility, procuring a background texture or organization to the field of experience. However, there is a big however. In spite of the historically consolidated psychopathological perspective, neuroscientific research applied to schizophrenia has so far almost entirely neglected the first-person experiential dimension of this syndrome, mainly focusing on higher-order cognitive functions like executive function, working memory, theory of mind, and the like. I am approaching schizophrenia from an alternative perspective, positing that schizophrenia is a self-disorder characterized by anomalous self-experience and awareness. And I think that this approach can shed new light on the self-disturbances and social deficits characterizing schizophrenia. And in that respect, I would like to start with the notion of the bodily self. The philosopher Sean Gallagher in 2000 wrote, even if all the unessential features of self are stripped away, there is a basic, immediate, or primitive something that we are willing to call a self. So my research agenda, as probably already transpired from my first talk, is to find the body in the brain, literally to find the brain bodily basis of implicit awareness of our own body and of the implicit relationship with others. And a few years ago, I proposed the notion of the core notion or basic notion of the self as bodily self in terms of power for action. What do I mean by that? I mean that there is a sense of body that is inactive in nature and that enables us to capture the most primitive sense of self. The body is primarily given to us as a source or power for action, which means as the variety of motor potentialities that define the horizon of the world in which we live, our Umwelt, to spell it using von Oeck's school words. So the basic sense of self we are dealing with is supposedly antecedent the distinction between sense of agency, I am the author of my actions, and sense of ownership. This arm belongs to me, is mine. The basic sense of self in terms of bodily self as power for action provides also, according to this hypothesis, a conceptual framework for the coherent interpretation of a variety of behavioral and psychopathological data, as I will try to do in the following minutes. The motor aspects of the bodily self provide the means to integrate self-related multimodal sensory information about the body and the world our body interacts with. This opens the possibility to relate our openness to the world to the motor potentialities our bodily nature entail. And I could refer to that using the notion of practognosia put forward by Merleau-Ponty. The schizophrenic spectrum has been described as a psychiatric condition associated with disorders affecting the functionality of a minimal self that Joseph Parnas described in terms of ipseity. According to Joseph Parnas, there are three levels of selfhood that can be identified. The first one, designated as ipseity, is constituted by the implicit awareness that this is my experience. The experience that we are all having now is ours. Such pre-reflective level of selfhood is sometimes referred to as the basic or minimal self, or as I said, ipseity. Then we have the more explicit awareness of self as an invariant subject of experience and action. And according to Joseph, this reflective level of self-awareness already presupposes the basic self, the minimal self. And finally, we have the narrative self. I will focus my attention on the pre-reflective level, the implicit awareness that this is my experience, or ipseity, to use Joseph Parna's words. According to Parna's, ipseity disturbance may account for many of the key phenomenological changes occurring during the prodromic phases of schizophrenia. Disturbance of mindness of experience or sense of presence appears to be one of the most critical features affecting ipseity, but it's not the only one. There are other anomalous experiences which include anomalous body experiences, stream of consciousness, self-demarcation, and existential reorientation. As I said, I will focus mainly on the corporeality aspects of ipseity. And one possibility to start dealing with that is to remember a famous notion introduced by Enricus Cornelius Rünke, the notion of Prägungsgefühl, Prägungs feeling, according to which we immediately grasp that there is something really strange with the patients we are dealing with, a reduced felt of interpersonal resonance that we grasp almost immediately, and which in turn affects our interpersonal relationship with the patient and his or her social functioning. And I think to make this more vivid, I would like to show you the opening sequence of a movie of a movie director which I really like, which is David Cronenberg, the movie named Spider, whose main character, performed in the movie by Brian Fiennes, is a psychotic patient. The passengers are leaving the train, getting out of the station. I think it must be Victoria in London. There's nothing strange about what we are seeing. People leaving the train, getting out of the station. But now look at this. Here it comes. And from the very beginning, we are looking at Ralph Fiennes. We understand there's something wrong with it. His movements, his attitude, his gaze, his looking around in a very suspicious way, where he keeps the notes pointing to the address where he's supposed to show up, in a sock. This passenger is really different from all the others that we saw before. Here comes Thomas Fuchs. I had the privilege to know him, to become acquainted. We collaborated for many years in 2 consecutive international training networks. So I visited Heidelberg many times. In 2005, he wrote, "Schizophrenic patient does not inhabit her body anymore. In the sense of using is taken for granted its implicit structure as a medium for relating to the world." To make this more explicit, I would like to read from a report from one of Thomas patients, a 28-year-old female schizophrenic patient. She wrote, "For some time, I had a feeling as if my clothes did not seem appropriate anymore. My gait had changed. I walked stiffly and did not know how to hold my hands. Then I often looked into the mirror and found that my facial expression had changed. And I began to think that I might be regarded as a prostitute. Men looked so strange at me. I took passport pictures of myself in order to examine whether I only imagined that. Then I began to feel a kind of charging or tension in my body when others came near to me, as if it were passing over from them. Finally, I thought I should be made a prostitute by brain manipulation." You see, there is a sort of dramatic escalation in the patient's own conception of herself, which starts with something strange with the body. She asked impossible question, how to hold her hand while walking, something we never think about, something that comes natural. We don't need to think how or where to keep our hands when we walk down the street. So there is a progression of this incapability to feel at home with their own body, which finally ends with the positive symptom, the delusional belief that her brain has been manipulated. So to spell it using Eugene Minkowski words, the rich autism, the positive symptoms is a desperate attempt of the patient to provide a meaning, a sense to a relation with the world that starting in her body doesn't make any sense anymore. So the question we started asking was if what has been described as the bodily self-advantage is or not preserved in schizophrenia. And I'll be clear in a minute. Bodily self in schizophrenia, the loss of implicit self-bodily knowledge. In previous experiments, we discovered that if you ask healthy volunteers in a matching to sample task to judge which of two images matches the target image at the center, they are faster and more accurate when the image to be matched belongs to their own body, although they are totally unaware of that. So we applied this paradigm to a group of first episode psychotic patients during remission. There were 24, average age 27. They were all later on diagnosed as schizophrenic. We decided to start with first episode patients in order to minimize possible confounding elements, iatrogenic factors like the psychopharmacological therapy. These patients were all under single drug medication with new generation antipsychotic drugs like quetiapine, risperidone, paliperidone, ariprazole, or olanzapine, and by using chloropromazine equivalent, we were in a position to exclude that any of the results that we got in this particular study were due to the pharmacological treatment. Basically, on this cohort of patients and the age-matched group of healthy controls, we ran two experiments. The first experiment I was describing before is a simple visual matching to sample task. We asked the participants, we took snapshots of their hands, of their foot, of their mobile phone, of their shoes 2 weeks before with an excuse. Then we ran the first experiment. So the participants, patients, and healthy controls were asked to determine which of the two feet, or which of the two hands, or which of the two mobile phones, of each of the two shoes match the target image at the center. In the second explicit experiment, there was no target image at the center, but either two shoes or two mobile phones or two hands or two feet. The question was, please tell me which of the two belong to you, be it the hand, the foot, the mobile phone, or the shoe. And here are the results. Clearly, controls were significantly more accurate in solving the implicit task when they were looking at, although unknowingly, to their own hand or foot, but there was no significant difference with inanimate objects. Clearly, this self-advantage is totally lacking among schizophrenic patients. With the explicit task, we replicated previous results, which quite surprisingly show that when you ask people to judge whether what they are looking at is their hand or their foot, actually there is no advantage, but there is a disadvantage. Their performance is very poor and equally poor for normal healthy controls and schizophrenic patients. The only difference is on the kind of errors the schizophrenic patients commit. They tend to misattribute more to the self images pertaining to body parts of the others than healthy controls. And again, no significant difference with inanimate objects. To wrap it up, schizophrenic patients do not show the self-advantage for their own body parts in the implicit task as shown by the healthy controls. Similarly to controls, they do not show the self-advantage when explicitly asked. This suggests that schizophrenic patients may have problem in activating a motor representation of their own body parts when looking at them. And such deficit shows the relevance of implicit motor representation of the body for a coherent sense of bodily self. Why am I saying this? Because we were able to extend these results on schizophrenic patients by applying another task that we previously published on healthy controls. This is a mental rotation task. Again, we asked all participants to come to our lab. We took pictures of their right and left hand, and 2 weeks later, we presented one at a time images of the right or left hand in various possible rotation. The task was very simple. Please determine if the hand you're looking at is a right hand or a left hand. And notoriously, in order to solve the task, you need to perform a mental rotation of the hand you're looking at. The more it is rotated from the canonical egocentric orientation, the longer it takes for you to give a correct answer. And again, the self-advantage in terms of reaction times, healthy controls are faster to solve the task when they are looking at their dominant right hand. They were all right-handed. This doesn't occur with schizophrenic patients. So patients did not show faster reaction time to self than others' right-hand stimuli, indicating, as expected, the absence of the self-advantage effect. A further interesting result of this study is that a significant lower slope value was found only for self-right-hand stimuli compared to controls, demonstrated the absence of mental rotation for self-stimuli. Why did I say that this relates to implicit motor representation? Because in a previous fMRI study performed on healthy controls, we revealed a neural network with this same task for the general representation of the bodily self, which encompasses the supplementary motor area, pre-SMA, the anterior insula, and the occipital cortex bilaterally. But crucially, the representation of one's own dominant hand turned out to be primarily confined to the left premotor cortex. This was the task. Again, people had to tell whether the hand they were looking at was the right or the left hand, and the inferior frontal gyrus on the left hemisphere, here represented in yellow, was the area specifically activated in the mental rotation of the self-dominant hand. So, there is something wrong with the bodily self in schizophrenic patients already at the level of the first episode, and we believe that the basic experience we entertain of ourselves as bodily self is from the very beginning driven by our interactions with other bodies. So I use a GIF taken from the first non-Polish movie shot by Roman Polanski with a very young Catherine Deneuve that you don't recognize here, which portrays the evolution of psychosis in a young Parisian hairdresser as an introduction to the intersubjective dimension of schizophrenia. In this experiment, we recorded the EMG of facial muscles of healthy controls and this time chronic schizophrenic patients in Parma with the collaboration of the Clinic of Psychiatry of my university, while all participants were looking at video showing two actors either crying or laughing or performing meaningless facial grimaces accompanied by non-emotional sounds. And quickly, here are the results. The zygomaticus major that in healthy controls activates during the observation of laughter and gets non-activated during the observation of cry or meaningless facial grimaces. In the case of schizophrenic patients, we see a much poorer and delayed activation of the zygomaticus during the observation of laughter, and an anomalous activation and incongruous activation of the zygomaticus while they are looking at someone crying. Furthermore, the patients who showed this lack of activation of the or disruptive activation of the facial muscles in response to the emotion of others were also those that revealed a poorer performance when attributing a positive or negative emotional valence to the videos they were observing. To concisely summarize, reduced facial mimicry in these patients affected the judgment of perceived emotions. Let us now turn to action and emotions. We ran this experiment, an fMRI experiment again, on first episode schizophrenic patients that were in turn requested to observe a goal-directed action performed by two actors grasping objects on a table, and this action could be performed by the actor with a neutral face, with an angry face, or with a happy face. In other runs, we show the actions without the head, or we just show the face showing anger, happiness, or neutral expressions. To make a long story short, observation of emotionally neutral actions evoked reduced frontoparietal activation of the mirror circuit in schizophrenic patients compared with healthy controls. So, particularly in the right hemisphere, inferior frontal gyrus and opercular regions in the right inferior frontal gyrus orbitalis part in the premotor cortex of the left hemisphere. The activation in healthy controls was significantly stronger, both to the neutral action and to the emotional action than in schizophrenic patients. Furthermore, activation of the left inferior parietal lobule, the so to speak, the parietal pole of the mirroring circuit, this activation in schizophrenic patients correlated negatively with the severity of their self-disorder that we evaluated with a Bonn basic symptom scale. We used the schizophrenia proneness instrument. So, in other words, the less they activated the parietal pole of the mirror circuit, the most severe were their symptoms as established through this instrument. It enables to have a rather detailed picture of the self-experience of the patients. Furthermore, observation of an action performed by an angry agent produced reduced activation of the right anterior insula in schizophrenic patients compared with healthy controls. As shown again in black, you see the healthy controls, in gray, the schizophrenic patients. And the less they activated the anterior insula, the lowest the score with the empathic quotient, the less their empathic capabilities. Let's now turn to the final part of the talk. We are again dealing with intersubjectivity. We are dealing with the observation of tactile experiences of others. First episode, schizophrenic patients in the scanner, as well as the healthy controls, were looking at videos showing tactile stimulation on the hand of a stranger that could be performed by an unintentional agent, the branch of a tree moved by a fan. It could be neutral, just a neutral touch, or it could be affectual. It could be either a positive touch, sensuous touch, a caress, or a hit. Here you see the activation in the posterior insular cortex of patients and healthy controls. While in the case of healthy controls, when they were observing particularly the affective touch on the hand of someone else, we saw a deactivation of the posterior insula. This activation was totally absent in the case of schizophrenic patients. When we are touched on our body, this leads to activation of a network, a complex network of brain areas, including S1, S2, the ventral premotor cortex, and an activation of the posterior insula, which probably is the neural correlate of the affective arousal that we experience when someone touches one of our body parts. But when we witness the contact on the hand of someone else, this is a different experience with respect to when our own body is activated. We see the posterior insula being activated. This deactivation resulted to be totally absent in schizophrenic patients. And indeed, a couple of those patients, as soon as they watched the video on the screen in the scanner, they pressed the red button because they said they saw themselves in the video. The borders of the bodily self, in other words, appear to be blurred in schizophrenic patients. And one way of backing up this statement is comes from the lack of self-other differentiation in the domain of affective tactile experiences, as I said, given the lack of the activation of the posterior insula in patients during touch observation. Another interesting difference between first episode psychotic patients and healthy control is the reduced activation of the ventral premotor cortex during the observation of all kinds of touches. For all these kind, you see the activation in the right hemisphere ventral premotor cortex in healthy controls. Practically, you don't see anything in the brain of first episode schizophrenic patients. And reduced activation in the premotor multimodal integration region and consistent correlation between bold response and basic symptoms. Again, the patient with the most severe symptoms were also those showing the weaker activation of the ventral premotor cortex, could reflect the neural basis of a reduced sense of a coherent bodily self in schizophrenia, which percolates, so to speak, also in the intersubjective social cognitive domain. In a further study that we carried out in collaboration with Georg Northoff, we studied the connectivity, the functional connectivity of these two nodes that resulted differently activated or non-deactivated in schizophrenic patients, the posterior insular cortex and the ventral premotor cortex. And it turned out that functional connectivity of these two brain areas was distorted in schizophrenic patients, in first episode schizophrenic patient. Functional interaction between the ventral premotor cortex and the posterior cingulate cortex were increased in first episode schizophrenic patients with respect to healthy controls. Functional interaction between the ventral premotor cortex and the posterior cingulate cortex significantly correlated with basic symptom severity. Again, the more severe the symptomatology, the most this abnormal connectivity between the lateral and the medial aspect of the brain was detected. Conversely, functional interaction of the posterior insular cortex with the posterior cingulate cortex and S1, the posterior central gyrus, were decreased in first episode schizophrenic patients with respect to healthy controls. Considering the sensory affective function of posterior insular cortex, that it's a recipient of a dedicated afference of C fibers that mediate sense of touch, and the posterior central gyrus and S1, and the mediation of self-experience that reportedly should be one of the functions of the posterior cingulate cortex, these results may reveal deficits in the processing of bodily sensory affective information as belonging to the self, contributing to the problem of the blurring of the self-other distinction that very often can be detected in schizophrenic patients. So to conclude, cognitive neuroscience can today address classic topics of psychopathology with a new level of description, finally enabling the correlation between the first-person experiential aspects of psychiatric disease that we can assess either by means of the Bonn Basic Scale Syndrome of the IAS scale of Parna's and their neurobiological roots. Brain function anomalies of multisensory integration, differential processing of self and other related bodily information mediating self-experience might be at the basis of the imbalance in the pre-reflected relationship of the embodied self to the social world observed in schizophrenia. Thank you for your attention.
Thank you, Vittorio. We all clap our hands virtually, and we thank you for this wonderful and excellent talk about the relation between body and self and the brain in schizophrenia patients. So until now, I only have one question from the YouTube chat. Please don't hesitate to type in some more questions. I give you some time by starting with my own question, my first question, and thank you for also stressing the history of psychopathology, which has German roots, and the first author you cited, Ernst Kretschmer, was also head of the department I'm glad to work in now after the Second World War, and he also brought up the idea of dimensionality in psychiatric disorders, and in particular schizophrenia. What do you think? Do we really have one schizophrenia as a disease entity, or are these different types of disorders which we sum up with the schizophrenia expression?
Well, first of all, I should say that I'm not a psychiatrist. I'm a neurologist, and I'm very fond of psychiatry. I think it's one of the branches of medicine which are most fascinating and revealing about human nature. I think you can have an obsessive behavior in a mice. Perhaps you can have depressed mice. I seriously doubt we have clear animal model of psychosis. I think that psychosis in negative revealed what being humans is all about. So in that sense, the recurrent use of the notion of a spectrum reveals how difficult it is to clearly define the borders of this particular kind of psychosis. On the other hand, I think that for experienced psychiatrists, not always, probably, but quite often, also because of this notion of the Praxisgefühl, it is quite revealing that not all psychotic episodes are schizophrenic. There is some specific quality in schizophrenia that sooner or later reveal itself. The notion of a spectrum betrays our difficulty, and the fact that even the Americans are now thinking critically. Even Nancy Andreasen has wrote papers challenging the sole monolithic fate in the DSM, reveals that the dimensional quality of nature is also part of psychiatry. So it's very difficult to answer your question. It's a very difficult question. My gut feeling is that dimensionality, at the very least, should be brought into the picture if we want to deal with mental disease. DSM is very useful. We can easily communicate across the world, so a diagnosis can be understood in many different parts of the globe. But I think we are far more complicated than summing symptoms for a given period of time. And the history of DSM also reveals it clearly. There are diseases that are regrouped, that appear, then magically disappear. So I think a more careful attention to the dimensionality of mental disease and a lot more of study of the historical roots of psychopathology can help younger psychiatrists to navigate more safely in this perilous ocean, so to speak.
Thank you for this very wise answer. So now I read the first question I have in the YouTube chat, and the only one until now. Luca Sergi Rinaldi asks, which is the relation between schizophrenia and creativity?
Good question. Well, the short answer would be, I don't know. I wouldn't know. I think I visited a couple of times the museum in Heidelberg of so-called brute art, and sometimes it's amazing to see what schizophrenic patient can produce in terms of art and creativity. But I think a tight coupling between schizophrenia or madness, broadly speaking, and creativity sounds a bit too romantic to my ears.
Okay. So I will go on with one of my own questions. I have a lot of them. I think from your talk it came very clear that we have to combine ideas from philosophy with modern neuroscience to get closer to this phenomenon of schizophrenia and schizophrenic disorders. What are your ideas to enhance this connection between philosophy and neuroscience? Do you have any special recipe for that?
Well, I think that psychopathology for a long time has been heavily influenced by phenomenology. There's no question about it. The prototypical case is that of Binswanger, but I could add Karl Jaspers, who was a philosopher himself. He not only read, actually, he had quite many disagreements with one of the protagonists of phenomenology, who was Heidegger. I don't know if it is really necessary for psychiatrists to be trained in philosophy, but I see that this is quite often the case. Many of the German psychiatrists I had the privilege to become acquainted and friend with Kai Vogelei, Thomas Fuchs, or Georg Nordhoff. They both have degrees in medicine, a specialization in psychiatry, and a degree in philosophy. I think when we are dealing with mental illness, we are dealing with the mind. So to know how the mind works, I think it is not enough to put people in a scanner and elaborate a complex statistical algorithm to determine what activates when. I think the questions, the reason why we put people in scanners is to have answer to questions. And these questions, when it deals to mental illness, have a strong philosophical background. So I think that for a psychiatrist training in philosophy, at the very least in philosophy of mind, I don't dare to say should be a must, but I think it would be very important.
Okay, thank you for that answer. So you showed us some examples of your own research on the very important and under-researched first-person dimension in schizophrenia. Yeah. Which is your favorite paradigm, and how can you further develop this experimental approach?
Well, we started with the SPI, then we are introducing EASE scale of Joseph Parnas. You see, the point is it's quite difficult because it's very time-consuming, and there are not many trained psychiatrists who are able to administer this questionnaires proficiently, but we are trying hard. In the future, we might also be interested in applying micro or phenomenological interviews. They have been developed, as far as I understand, by Ptimanjan and Nathalie Depraz in France. So I have former collaborators of mine who trained themselves with this technique, notably Catherine Hyman, who was my PhD student in Parma and now is a researcher in Aarhus in Denmark. So it's very difficult and time-consuming, but I don't give up. I think what's most interesting in psychopathology is to become acquainted with the first-person experience of being psychotic, and even more interesting for me as a neuroscientist is trying, I would say, desperately to find significant correlation with this way of quantifying in a quantitative way the qualitative experience of being psychotic with the readout of our fancy, expensive toys like fMRI or high-density EEG, MEG, or other kind of empirical approaches. I'm not entirely sure that self-disturbances or deficit in ipseity is a unique feature of schizophrenia. I had long discussion with many psychiatrists. Of course, this is a point of view of Joseph Parnas, but we would be very much interested to test with this very same approach other psychiatric diseases. I have the suspect that mental disease is a mosaic where many components can blend to provide different composition, different mosaics with a very limited element, a number of disturbed elements. But this is a long story.
Okay. Yes. Just to move on, you used in your talk and your experience in own research many different methods, from neuropsychology to EEG to electromyography to fMRI, but you did not use, at least I did not recognize it, genetics and epigenetics. What is your view on the possible contribution of these methods for investigating schizophrenia disorders and their symptoms?
Well, I think it's very important. I don't have the manpower and the resources in my lab to carry on this kind of research. So ideally, a possible dream, maybe it could in the long run become true in Tübingen, I don't know, would be to combine the approaches I dealt with and very quickly summarized in my talk of today with these approaches. I think we need all the firepower to shed light on this incredibly complicated mental disease. So I'm fully with you. I can't do that, but I think in principle it should be done.
The last chance to put a question into the YouTube chat, because I don't have any further question, and to have some time, I will put my last question, which is a more clinical one. So in Germany, we have quite a lot of inpatient facilities for patients with mental disorders. And from our daily experience, we have the feeling we would use it, and we could not treat the patients correctly and intensively without these inpatient beds. So for example, in our hospital, we have more than 180 inpatient beds, which are full every day. And we get admissions several times per day on emergency. So since Basaglia in Italy, you don't have a lot of inpatient beds, how does it work? What is your experience? Is it working without inpatient beds? Psychiatry?
Well, there is a limited number of inpatients. Well, it depends where you are and where you go. The situation is really patchy. In parts of the country, the system, I would say, works reasonably well. There are foster home with daily care, territory psychiatry. I mean, me and my wife, who's also a colleague, were married in City Hall by Mario Tomasini, who was a collaborator. He was not a psychiatrist. He was a volunteer, but he collaborated with Basaglia and was one of the key figures that opened the asylum in Colorno, a century-old asylum in the countryside near Parma, and he was the founder of many of these protected homes where many of these patients found a new life. This is a very complex issue. I think most of the time the answer you get, there is no money. I think the problem is not that there is no money, but politicians prefer to allocate the money elsewhere. I think probably you should have both, but I still don't give up with the idea that with a proper psychiatric treatment for many cases, the solution is that and should be pursued. Unfortunately, in many situations, the families are left alone to deal with relatives that cannot be handled, of course, at home. And this is a big problem for many people in Italy, but I assume also elsewhere.
You have received another question in the chat from Togoron, who asks, how can deficits in abseiety be improved in patients when they are in therapy?
That's a very good question. I think, well, we actually tried to approach this problem with a colleague, a psychiatrist in Perugia. The number of dropout prevented us to publish any meaningful result. We just published in a journal a single case. For example, that particular treatment consisted in interpersonal relation in a pool, in a water pool with the therapist that were also video recorded, and then the group of patients were observing their interaction with the therapist in the pool and commenting on that. And we recruited originally 25 patients. It was meant to be a longitudinal study, but after 1 year, there were only one patient that could be followed for the entire planned sequence of intervention. In this particular case, this patient had very strong negative symptoms. He was also abused. He was, I think, the son of a big shot of the mafia. This patient, through this treatment, which again, I repeat, was based on interaction, gentle bodily interaction in water, followed by a group discussion of those video footage. The negative symptom greatly reduced. There was a very how do you say, rich positive phase, which worked like a kind of unblocking. And then with psychotherapy, the situation greatly improved. We tried to replicate in Rome, in Santa Maria della Pietà, this, but for the time being, we were not able to do it. So I think this kind of combined physical intervention and later on observation of the physical intervention with the in a psychotherapeutic group environment is one possible way to go. But again, I mean, this is not my job. I'm not a psychiatrist. So this is what we try to do, but with very limited resources. So this is something that if I had the means to continue, I would bet on this. I would be curious to carry out a true longitudinal study with a much bigger cohort of patients. For the time being, this was impossible for me.
Okay. Thank you very much. We don't have any further questions in the chat. I thank you. It was a really great pleasure to listen to your talk and to discuss your results and the problems related to it. And we are all looking forward to seeing you in the next Gallese talk, which will be in July. You all have the program. And even more to seeing you in person in next year when you will have a Humboldt guest professorship in Tübingen, and maybe we can put some of your ideas into praxis in our hospital in the research sections. So I thank the audience for listening and contributing, and we all wish you a very kind and nice evening, and thank you again, Vittorio.
You too. I don't say anything, but I wish you a very nice evening.
Okay, goodbye.
If you know what I mean.
Yes,
Bye-bye.
bye.
See you soon. Thank you.